All right, guys, welcome back to Underground Science. In this video, we'll be talking about transposition of great vessels. All right, so let's go and get started. So, what is transposition of great vessels? So, in this disease, right, in this congenital defect, congenital heart disease, right, it's one of the many cyanotic heart diseases that we will be talking about, right? So, this is a cyanotic congenital heart disease. Okay, and the reason why it's cyanotic is because you see, quite you see high amounts of cyanosis and pretty early on actually in this disease. So what happens here is it's in the name, right? So transposition of your great vessels. The great vessels get switched around. Now remember, normally we have our heart. I'm just going to draw a simple picture here. From our right ventricle, remember, where does the blood go? It goes to our pulmonary artery, right? And normally from our left ventricle, blood goes to your aorta and then to your systemic circulation. In transposition of great vessels, what happens is due to an embryological reason, right? Remember, your aortical pulmonary septum has to spiral 180 degrees, but it doesn't, okay? And because it doesn't, you instead of your right ventricle feeding into the pulmonary artery and your left ventricle feeding the blood into the aorta, it switches. So then once the baby is born, right, and you were to do an echocardiogram, what you would see is the left ventricle is pumping blood to the pulmonary artery and the right ventricle is pumping blood to the aorta. Okay. And right away, we can think why that's bad is because normally, right, if we say what happens normally from the deoxygenated blood goes from the body, right, enters via the superior and inferior vena cava, goes to the right side of the heart, then goes to the right ventricle, right, after the right atrium. So then you get to the right ventricle, then that goes to the pulmonary artery, to the lungs, then from the lungs to the left atrium, then left ventricle, then to the aorta, right? That's the normal pathway of blood through the heart and then to the body. But here now, what's going to happen in transposition of great vessels is actually going to be really bad. It's not going to be good because what's going to happen here is you're going to have blood coming from the body that's deoxygenated. It's going to go to your right atrium, then to your right ventricle, then to your aorta, right? Then after the aorta, after it comes back around, what did we say? Where did we say the blood from the body goes? Back to the right atrium. So you create an independent circuit, right atrium to right ventricle to aorta to body, back to right atrium to right ventricle, aorta, body, and you create this independent circuit. Remember, the blood that's coming to the right side of the heart is deoxygenated. So now what happened is we have a independent deoxygenated circuit. Now let's go to the left side of the heart. In the left side, we have, so let's just choose red, right? So left side, we have from the lungs to the left atrium. Let's draw that better, sorry. From the lungs to the left atrium, to the left ventricle, to the, not the aorta. Remember, this is going to be to the pulmonary artery, okay? Then from the pulmonary artery, where does blood go? Usually to the lungs, right? So now look what happened on the left side of the heart is from the left ventricle, you go to the pulmonary artery, then to the lungs, then back to the left side of the heart, which is usually what happens, right? And then now you created a oxygenated circuit. So this circuit is purely oxygenated because we involve the lungs here. Okay, so that's actually really important. This is the main part of this transposition of great vessel disease, right? You have all the blood in this circuit is deoxygenated. All the blood in this circuit is oxygenated. But not these two circuits aren't connecting, right? So if we don't connect these two circuits, like this is very fatal. Okay, so that's why transposition of great vessels can lead to early cyanosis and death if not treated quickly. All right, so now we know the reason why. So if we just go up and do a quick review of what we just said, another important thing that we will make a video on later, maternal diabetes and transposition of great vessels are associated with each other. Okay, so that's really important to know. So now that we know that the left ventricle is connected to the pulmonary artery and the right ventricle is connected to the aorta, right, creating two independent circuits, right? So just to test our knowledge again, the left side of the heart is involved in the oxygenated circuit, and the right side of the heart is involved in deoxygenated circuit, right? So what we got to the conclusion was, or the conclusion that we got to was that we need a connection between these two circuits, or it's going to be fatal and early death will be involved, right? So as we said, we have two separate circulations. It never mixes. Those two circuits never mix, right? There is no oxygenated blood going to the systemic circulation. Okay, it's it because as we saw on the right side of the heart is connected to the aorta, and deoxygenated blood comes back and then into the aorta and then to the rest of the body and back. Like there is no mixing, okay, between the right and left sides of the heart. So there's no oxygenated blood going to the body at all. Okay, so that's why you need mixing for survival. All right, so how do we get this mixing to occur? Either we need an ASD, an atrial septal defect, or a VSD, a ventricular septal defect, or a PDA, which is a patent ductus arteriosus. Okay, any of those three will help the baby at least get some oxygen going to the systemic circulation. All right, so let's see what we have next. So like we were saying, right, we need an ASD, VSD, or PDA, some sort of connection between the left side and the right side, between the oxygenated circuit and the deoxygenated circuit, right? So what we can do as an ASD is the first option that we talked about. But how will an ASD help, right? So if we see a simple picture of the heart like this, right? And then we see the right atrium, right ventricle, left ventricle. So remember that after the right ventricle, the right ventricle dumps its blood into the aorta, okay, in this disease, right? Not normally. And the left ventricle is dumping its blood into the pulmonary artery. If we were to make an ASD, which is a connection between the right and left atrium, so let's go ahead and make that connection. Right now we have an ASD here for blood to flow between the two atria. Then what's going to happen? So which side is the oxygenated side? The left side, right? Because that's connected to the pulmonary artery, which then goes to the lungs, brings back fully oxygenated blood to the left side. So we have the oxygenated circuit on the left side. If this ASD is present, then the oxygenated blood can finally cross over to the right side. Then that oxygenated blood can go to the right ventricle and out to the systemic circulation, right? So that's how an ASD is really, really helpful. It's actually the most effective site of mixing, all right? Because it allows the most amount of blood that's coming from the lungs to directly enter to the other side of the heart and go to the systemic circulation. Okay. Now, the other option we discussed was the VSD, right? So if we drew another heart picture here and and we saw why a VSD will help also, right? So if we just drew a big space like this, we make a VSD. And let's just highlight the fact that we have a huge space now between the left and right ventricle. So now we have a VSD, right, in this case. So again, Who's the oxygenated circuit and who's the deoxygenated circuit? The left side is the oxygenated circuit, right? Because we have our blood leaving the left ventricle, going to the pulmonary artery, going to then to the lungs, getting oxygenated, coming back, and we have the circuit. Again, it's the same thing, right? If blood goes down to the left ventricle, that's fully oxygenated, it can cross over to the right ventricle, then go down to the aorta, and then to the systemic circulation. Okay, so that's why VSD is also helpful. But it turns out that the VSD is actually less efficient, okay, than an ASD. In fact, the VSD can overload the lungs, right? Because what happens is eventually all this blood that's going to go to the right ventricle and aorta, we said, will then go to the systemic circulation, then come back and return where? To the right side of the heart, right? And when the blood comes back, right, to the right side, then it goes to the right ventricle. And from here, some of that blood can cross over, right, to the left ventricle. And where is the blood going from the left ventricle? To the pulmonary artery, which will go to the lungs. So do you have not only do you have the blood that's separately in the left side, okay, that's involved in this circuit, but on top of that, you have blood from this circuit on the right side. Some of that will cross over, right, through the VSD and can go to the left ventricle, then to the pulmonary artery, and then to the lungs. Okay, so that's why you can get pulmonary overload in a VSD, right? You can overload the lungs with excess blood. Now that we talked about ASD and VSD, let's talk about how a PDA is involved here, right? So if we drew a picture of a heart like that, we labeled it, right atrium, right ventricle, left ventricle, and left atrium. Okay. So, right, in a PDA, what does a PDA do? A patent ductus arteriosus. It connects the pulmonary artery, right, to the descending aorta. Okay. So usually it connects the pulmonary artery to the descending aorta, right? So if we just look, we know the aorta is coming off, we know the left ventricle is pumping to the aorta, right? So if we just look at the aorta itself, let's say that we have our left ventricle right like this, and then we draw a diagram like this showing the aorta, and then we know off the aorta we have our brachiocephalic trunk, our left common carotid, and our left subclavian, right? So let's go, that's not good. Let's go ahead and just quickly draw that in. And then from there, we know we get our descending aorta, right? Like this. So our patent ductus arteriosus, right, is right here. It's after the three branches. So if we get our eraser here, and let's just say for the purposes of this video, let's just say it's right here, where we have our patent ductus arteriosus, and we can just draw our pulmonary artery connected to this, right? Like that. So if we draw something like that, I know this isn't anatomically perfectly accurate, right? It's just for purposes of understanding what a PDA is. It's where we get our pulmonary artery dumping blood into the descending aorta. So after the three branches have occurred, after that we have our PDA present, okay, which is right there. And this right here in blue is our pulmonary artery. In this case, in transposition of great vessels, or transposition of great arteries, right? We have our pulmonary artery is oxygenated, okay, which is not the usual case. Usually, our pulmonary artery is deoxygenated, right? Because that's connected to the right side of the heart, which has deoxygenated blood in it. In this case, though, because our pulmonary artery comes off the left ventricle, it's oxygenated. So imagine that if, just to clarify quickly, the blood going out of these vessels, right, our brachiocephalic, our left common carotid, left subclavian, is going upwards, right, to the head, neck region, and our arms. And the blood in our descending aorta is going to our limbs, right? Our lower body area, abdomen, lower body. So if there's oxygenated blood in our pulmonary artery, in this case, in transposition of great arteries, right? Fully oxygenated blood that's dumping into the descending aorta. And remember, what is the aorta in this condition, in this congenital defect? Where is the blood coming into the aorta from, right? It's coming from the right side of the heart, which is carrying deoxygenated blood. Remember the right ventricle. So remember the right ventricle pumps into the aorta. So the aorta already has deoxygenated blood, right? But then the pulmonary artery, due to the patent ductus arteriosus, is dumping oxygenated blood. So that means then that the blood going to the limbs are going to be oxygenated, right? The blood going to the limbs are going to be oxygenated. Okay, so the lower limbs specifically, right? So your legs are going to be oxygenated, or at least more pinker than usual, right? Not fully oxygenated, but more pinker than usual, right? So they're going to be more pink compared to the arms, right? So specifically, the right arm. We'll explain why in a bit. But the right arm of the baby will be blue, okay, or deoxygenated. And again, the reason why is because what blood is going up the aorta? Deoxygenated, right? Why? Because it's getting blood from the right ventricle. So that's why it's deoxygenated blood in this condition, right? In transposition of great arteries, not normally, right? In this condition, though, we have deoxygenated blood coming from the right ventricle going into the aorta. So that means exiting these three branches of the aorta is going to be deoxygenated blood, which is why in the right arm, you're going to see it's going to be blue. Now, clinically, we say preductal, right? So preductal meaning what? Before the ductus arteriosus, which is right here. So any all of this, right? Preductal is we depict that um, as the right arm. Okay, that's the blood going to the right arm. Specifically, the the so we what are these three branches right off the aorta? So let's draw it again. So specifically, if we draw the branches again off the aorta, right? So these three branches, we have the brachiocephalic trunk, right? We have the brachiocephalic trunk. We have the left common carotid and the left subclavian, right? Those are the three branches off the aorta. Now, the descending aorta, so afterwards, right, this part that goes all the way down, that supplies blood to your lower body. But the three branches that we just talked about supplies blood to your upper body, right? So your head and neck and arms. So if we looked at that, what branches, what two main branches, right, off the brachiocephalic trunk, what are the two main branches? So we know that off the brachiocephalic trunk, we get our right subclavian and we get our right common carotid. Now we know our right common carotid branches into the external and internal, and our internal carotid arteries supply our brain, right? Our right subclavian, though, will help supply blood, oxygenated blood to our right arm. Same thing with our left subclavian, right? Our left subclavian will help supply blood to the left arm. The right common carotid and the left common carotid will help supply the neck and head, right? So those are the branches of the aorta, or specifically of the brachiocephalic trunk, common carotid, left common carotid, and left subclavian. So if we were to depict where the patent ductus arteriosus is, we said it's right around here, right? Where the pulmonary artery feeds in. okay? So anything this side of the patent ductus arteriosus, or the PDA, will be called preductal. And anything after the PDA will be called postductal. So when talking about these types of congenital defects, or these congenital diseases, it's important to know these terms, postductal and preductal, because the way we depict preductal is by looking at the right arm, right? Because like we said, when blood goes through the brachiocephalic trunk into the right subclavian, that blood goes to the right arm. Because the right ventricle is pumping deoxygenated blood into the aorta in this condition, that means deoxygenated blood will reach the right arm. So preductal is depicted by looking at the right arm, which we just said has a bunch of deoxygenated blood coming to it. So that will look blue. Postductal is depicted as looking at the legs. Now we said that the pulmonary artery, right, dumps oxygenated blood into the descending aorta. Why? Because the pulmonary artery is getting blood from the left ventricle in this condition, which is fully oxygenated, right? The left ventricle is pumping fully oxygenated blood into the pulmonary artery, which then dumps into the descending aorta. And where did we say the descending aorta supplies blood to eventually? To the legs. So that's why the leg will look blue. Will look pink, right? See, I'm writing pink with the blue color though. So I'll just write it in white, right? So the legs will look pink, while the right arm depicted as preductal will look blue. Okay, so this is indicating deoxygenated blood, and this is indicating oxygenated blood, right? And this is different this is different from coarctation of the aorta, the infantile type, right? Which we'll talk about in another video. But this is what reversed differential cyanosis is, right? So that's important to remember. In transposition of gray arteries, you see reversed differential cyanosis, which you see the legs being pink and the right arm being blue. And why is it reversed? Because usually, as you would see in infantile coarctation of the aorta, usually you would see differential cyanosis, right? Or classic differential cyanosis, which is leg would be blue and right arm would be pink. And why would you see that, right? So we'll go into this in another video, but let's just quickly differentiate it here. We went in depth of why you see reversed differential cyanosis in transposition of gray arteries with PDA, right? But let's see quickly why you would see classic differential cyanosis in infantile coarctation of the aorta. So if we just draw the aorta, right, and then we draw its branches, brachiocephalic trunk, left common carotid, left subclavian, then down goes the descending aorta, right? And we said right around here, so let's draw another color, right around here, let's say right around here is going to be our PDA, where the pulmonary artery will dump its blood, right? Now, in coarctation of the aorta, after the three branches, okay, after the three branches, we have preductal coarctation of the aorta, or preductal narrowing of the aorta. Remember, we said preductal is before the ductus arteriosus, so somewhere here, but after the three branches of the aorta, we have narrowing, and that's preductal, right? You see that in the infantile type. So if we draw a narrow aorta like this, right? Basically like that, and then it gets to normal, right? If we draw a narrowing like that, but this is preductal though, then that means that blood is not able to get from here past the ductus arteriosus and into the descending aorta, right? Because this part is very narrow, right? So blood cannot get through. But then we said the pulmonary artery is dumping blood though past it, right, is dumping blood past the coarctation. So the lower body is getting blood from the pulmonary artery. But in infantile coarctation of the aorta, what blood is going into the pulmonary artery, right? We have blood from the right ventricle going there, right? Everything is normal in infantile coarctation of the aorta. We don't have any transposition of gray arteries. So the right ventricle is pumping deoxygenated blood to the pulmonary artery. Then that pulmonary artery is taking that deoxygenated blood and dumping it into the descending aorta after, after, right, the coarctation. This is the coarctation. We're having blood from the pulmonary artery go into the descending aorta after the coarctation. So we have deoxygenated blood making it down to the limbs. So the limbs will be blue. And before the ductus arteriosus, again, we said is the what? Coarctation, right? Before. So it's preductal. So that would mean that the blood in the aorta here is normally, right, in good amounts, reaching the brain, neck, head, and arms, right? So that's why, if what did we say we depict preductal as? Right arm. So the right arm in this case, right? So let's actually write it out. The right arm will be pink, right? Because blood has no problem going out into these branches. It only has problem going past the coarctation, right? So blood can't go past the coarctation, right? But then we have the pulmonary artery dumping its blood after the coarctation. So we do have blood going down to descending aorta into the lower body, but it's from the pulmonary artery. And the pulmonary artery has deoxygenated blood. So that's why the lower limbs will be blue, but the right arm will be pink. Okay? This is classic differential cyanosis. Okay, this is classic differential cyanosis. What did we see in transposition of gray arteries? The opposite. We saw the lower limbs were pink and the right arm was blue. That's why that was called reversed differential cyanosis. Okay, that's why that was called reverse differential cyanosis. So hopefully we understand the difference now between reverse and classic differential cyanosis. All right, so now that we went over that, let's look at some clinical features, right? Clinical presentation. So of course you're going to see severe cyanosis immediately after birth, right? And it's going to get much worse as the ductus arteriosus begins to close. Remember, when the baby's born and after a few days, the pulmonary vascular resistance begins to fall, right? The baby's able to expand their lungs, start getting oxygen in there, right? Because remember, in as a fetus and as they're developing, the lungs are filled with fluid, okay? But when they're born and they start breathing on their own, pulmonary vascular resistance falls. They're able to expand their lungs and get that oxygen in. So oxygen levels start to rise. And when when oxygen levels start to rise, that triggers the ductus arteriosus, the patent ductus arteriosus, that triggers it to begin closing, right? It starts to close. So remember, in transposition of gray arteries, the PDA was the only connection between the two independent circuits, right? So now if that starts to close, that's going to lead to severe cyanosis, and obviously it's going to lead to that can lead to severe shock, metabolic acidosis, profound hypoxemia, and went over the reason why, right? If we have our aorta here and its branches, and then we come after the branches, we said the PDA is right here, and the pulmonary arteries dumping oxygenated blood here, right? Because the left ventricle is pumping oxygenated blood into the pulmonary artery in transposition of gray arteries. So we have a bunch of oxygenated blood that's getting pumped here. And this is the only connection, right, between the two circuits. Now, if this PDA starts to close, initially you're not even getting oxygen to your head and neck and arms, right? Because what kind of blood is flowing into the aorta? From your right ventricle, right? Which is deoxygenated. So already you have cyanosis, we said in your right arm because that depicts preductal. And now on top of that, the PDA starts to close, right? A few days after birth, as the pulmonary vascular resistance falls and oxygen levels rise, right? In terms of the baby's lungs expanding, if the PDA starts to close, then now you don't have any oxygenated blood going to the lower limbs either. So now the whole body's undergoing cyanosis. And we know that if you don't get oxygen to your tissues, it switches to anaerobic respiration. And the byproduct of anaerobic respiration is lactic acid, which can cause severe lactic acidosis and metabolic acidosis, right? And of course, if you're not getting any oxygen throughout your body, that can lead to severe shock, right? And like we said, you're not getting any oxygen, so that can lead to profound hypoxemia. So that's why severe cyanosis within hours of life occurs, especially after the PDA starts to close. All right. So that's important to know. And if we look at another test called the hyperoxia test, if you give 100% oxygen to these babies, what will happen? If a baby has transposition of great arteries and you give 100% oxygen, will the oxygen levels normalize? Why or why not? Right? So if we look at the circuit one more time, and okay, so let's say you put a non-rebreather, you put the oxygen tank to 15 liters a minute, right? And so you're giving 100% oxygen. So what, let's follow the path. So that oxygen will go where? To the lungs, right? From the lungs, where does the blood return to? To the left side of the heart, right? Okay. Then from the left atrium, blood goes to the left ventricle, right? From the left ventricle, where does blood go to in this disease? To the pulmonary artery. Then, where does blood go from there? To the lungs, back to the left atrium, back to the left ventricle. And like we've discussed a lot of times already, that's its own independent oxygenated circuit. So you're giving all this oxygen, but is it ever making its way to the aorta and to the systemic circulation? No, right? Because that's on this side, right? It's never this oxygen that you're giving through a non-rebreather. 100% O2 is never making its way to the systemic circulation. So giving 100% O2 will not normalize the arterial oxygen levels. So that's why the hyperoxia test will fail. Okay, so that's another important clinical presentation to know. Now, let's say you're auscultating the baby, right? What heart sounds will you hear? So normally, if we look at heart sounds, right, we have S1 and S2 normally, right? We also have S3 and S4, but normally it's lub dub, which is S1 and S2. S1 we know is the closure of your mitral valve and your tricuspid valve. S2 we know is the closure of your pulmonic valve and your aortic valve. Okay, so S2 is divided into two different sounds, your pulmonary valve closing and your aortic valve closing. Usually, your aortic valve closes first because your left side of the heart's under much higher pressure than your right side. So when your left ventricle pumps into the aorta, that back pressure, right, going back into the aortic valve is much higher than the right side of your heart. So your aortic valve closes first. So if we see how your S2 sound looks like, usually we would draw something like this, right? S1, S2. But if we zoomed in on the S2, it would actually be like this, where you can see if this is time, right? If this is, I don't know why I drew that. If this is time, for example, the aortic valve closes first, okay? Because it's under higher pressures than the pulmonic valve. But what happens in transposition of great arteries is the aorta actually turns out to be much more anterior and closer to the chest. So when the aortic valve closes, it's much, much louder. Okay, so the A2 actually in transposition of great arteries is super loud. All right. And what happens to the P2 then, right? The pulmonic valve is actually much more posterior and lower pressure, right? So the P2 is very soft and inaudible. So when you're auscultating, it's not like the P2 isn't happening. There is a pulmonary valve closing, it's just you can't really hear it. So that's why you hear one loud snap, which is your aortic valve closing really loudly. Okay. So that's important to know also. One last important thing that we should discuss when talking about tests and imaging and diagnosis and all that is if you do an X-ray, right, it's important to know this term, especially right for the USMLE, is try to remember egg on a string sign. Okay, egg on a string sign. So you will see egg on a string sign in a chest X-ray. Why? Because in transposition of great arteries, you have a very globular heart. Okay, you have a very narrow mediastinum, right? However you want to pronounce that, mediastinum. You have a very narrow mediastinum globular heart, and 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 that's there. That's you have a narrow mediastinum because of the straightened great vessels, right? So that's why you would see egg on a string sign. Um, and then of course, don't forget the gold standard imaging here would be an echo. And is this why is this a gold standard imaging? Because if you do an echocardiography, what will you see, right? You're going to see clearly the left ventricle connected to the pulmonary artery and the right ventricle connected to the aorta. Okay, so you can confirm that with an echocardiogram. Okay, so that's really important to know. Um, and let's see, I'm trying to think of anything else. So I guess now we can just talk about the treatment real quick since this video is already way too long, right? The treatment here, like we said, is to make an opening between the two circuits, right? So what we could do is immediately start prostaglandin E, prostaglandin E, specifically E1. Why, right? Remember, prostaglandin E1, what's its job? Its job is to keep the PDA open. So it keeps the PDA, the patent ductus arteriosus, open. And that's very important because remember, we said that's the only connection between the two independent circuits. So at least this way, the lower body will be getting some oxygen, right? So prostaglandin E1, give that immediately to keep the ductus open and allow the pulmonary artery to mix into the aorta, right? To dump its blood into the descending aorta. And then another really important procedure, it's actually a surgical procedure, and this procedure is super cool. Okay, it's called the Rashkind procedure. Probably not pronouncing that right, but it's called the Rashkind procedure. And what this procedure is, right, what the goal of this procedure is to make a communication chamber between the two atria. Okay, so if you have the atria like this, right, and we said, I mean, it's similar to the reasoning that we use for an ASD, right? So if you make a communication between the two atria, then any blood that's coming to the left side of the heart, which is oxygenated, right? Because remember, this is going to the pulmonary artery to the lungs and then back to the left side. So any blood coming here is really oxygenated. If you create a communication barrier between the left and right atria, then that oxygenated blood can come to the right side, go to the right ventricle, and to the systemic circulation. So that's what the Rashkind procedure does, right? It's a balloon atrial septostomy. All right, so that's pretty cool. And it actually, what it does is it leads to a immediate improvement in the oxygen saturation of the baby. All right, because like we said, now that oxygen is able to get to the aorta and systemic circulation. but that's a stabilizing surgical procedure. We want something definitive, right? So the definitive repair in this case will be another surgical procedure called the atrial switch operation, right? These are super cool because like you get right. There's so many different types of surgeries that one can do to fix everything, right? So this is not the atrial switch, sorry, the arterial switch operation, right? And it's kind of in the name, right? Because in the first 1 or 2 weeks of life, if you do this, the arterial switch operation, what you can do is take the great arteries, in this case, the pulmonary artery and aorta, and you transect it and reattach it to the correct ventricles. So instead of the aorta coming out of or instead of the left ventricle dumping into the pulmonary artery, you take out that pulmonary artery and make it connected to the right ventricle. And instead of the right ventricle dumping its blood into the aorta, you would take out the aorta and connect it to the left ventricle. So if you transect the great arteries like that and reattach them to the correct ventricles, that way you're creating the proper circuit that's supposed to be there, right? And then of course you can take the coronary arteries and reimplant it into the new aorta. Okay. So and why did we mention the fact that this arterial switch operation has to be done in the first 1 to 2 weeks of life, right? Early on, it has to be done early on. And why is that? Okay, and this is actually pretty cool. So early on, right, the left ventricle is still conditioned to handle systemic pressures. Like we know that the left ventricle is connected to the pulmonary artery, but it's still the left ventricle. It's still conditioned to pump against systemic pressures, right? But if you wait too long, then that conditioning will go away. And if the left ventricle deconditions, because over time it's going to get used to pumping against a low pressure circuit, right? Because the pulmonary artery isn't even close as high of a pressure compared to the aorta. So if you wait too long, then the left ventricle will decondition, the muscles will get acclimated to a low pressure environment, and then you do the arterial switch operation, where now you make the left ventricle dump into the aorta, right? It won't be able to handle that pressure. Okay, it won't be able to handle that systemic pressure if you wait too long. And then that's even worse because then now you're kind of like in heart failure where you can't even pump adequate amounts of blood into the systemic pressures, into the systemic circulation due to the high systemic pressure. Okay, so it's important to do this arterial switch operation pretty quick. All right. And that's basically transposition of great arteries. I know that was way too long of a video. I hope it wasn't too confusing. I hope this video helped. And thank you guys for watching and see you guys in my future videos.